Love to travel and to study, and we studied all kinds of things. We studied prolotherapy, PRP, ozone therapy, osteopathy, and other things. And we incorporated that into our practice in our clinic. With regard to ozone, I took the AE Promo certification course in Madrid with Dr. Adriana Schwartz and Dr. Martinez Sanchez from Cuba, and who's one of the leading ozone scientists in the world. I had a paper published in the AE Promo journal. It's called the Ozone Global Journal, and it was a case study. And I've been lecturing on ozone quite a bit, but this is the first time I'm lecturing on the subject of combining ozone with stem cells and exosomes. It's an interesting and timely topic. And in our clinic, we had to decide, since we use ozone quite a bit in our clinic, we had to decide how to combine ozone with these biologic materials. And knowing what I know about ozone, it raised a lot of questions in my mind. And I noticed that not only in our clinic, but throughout the world, people are using ozone with stem cells and exosomes. But knowing what I know about ozone, it occurred to me that there are some problems with doing that, some things that should be considered. And in order to have an intelligent approach to doing this, you have to understand the biology of how ozone works in the body. And if you don't understand that and you're just thinking of in terms of combining ozone directly with these materials, you're going to have problems because ozone is fundamentally it's an oxidative treatment. So if you are going to introduce it directly with stem cells and exosomes, you have the problem is you're going to damage possibly these materials. So I'll get into specific recommendations and guidelines that I use later, but I'll start out by saying that we do not use ozone and exosomes and stem cells in the same day. We recommend having a separation of at least a day, and I'll get into more specific guidelines. But what I'd like to, the takeaway that I'd like you to have from my lecture today is not to think of combining ozone directly with these cells and exosomes, but to think of ozone as affecting the environment into which you're going to introduce the stem cells and exosomes. So we start out by why would you even want to combine ozone with exosomes and stem cells? The reason is that, well, we know that stem cells and exosomes work by paracrine signaling and paracrine signaling, right? So if we're going to use this, we're going to get better outcomes if we have a non-inflammatory environment. If we're starting out with damaged, inflamed tissues, we're going to have less quality of the signaling, the regenerative signaling. So what we want to do is we want to have a better environment in which to introduce it. And ozone can work very well. Just keep in mind that, like I said, we want to be improving the environment, not altering the cells that we're using. So the idea, again, is redox conditioning. So ozone modulates inflammation, improves microcirculation, activates adaptive antioxidant responses, influences immune signaling. So the concept, again, the important takeaway concept here is to optimize the biological environment to improve regenerative therapy outcomes. Exosomes versus stem cells. Now, stem cells are living cells that release cytokines, growth factors, extracellular vesicles, and exosomes, whereas exosomes are the cellular components. They're not the cells themselves. This becomes important when you're looking at timing of when to use ozone in relation to these substances, because as we'll see, stem cells are more sensitive to redox than exosomes. So we have a little bit more flexibility in timing with the exosomes than with the stem cells. So ozone, Dr. Medina covered some of this. I'm not going to repeat too much of it, but ozone reacts with lipids, antioxidants, and proteins to produce hydrogen peroxide and liquid oxidation products. So that the hydrogen peroxide is more of a short-acting reactive oxygen species. The LOPs are more long-acting, and these then result in secondary redox signaling molecules, which we'll get into. So this is an important slide. Usually, the concept of hormesis is very important to understand. The slide, the graph on the right. Usually, when you talk about hormesis, it's usually an upside down U. For some reason, they did it the opposite way in this graph. But the upside down U signifies that we want to use low dose ozone. We don't want to bombard the body with ozone. It's kind of like a very simple example is exercise, right? So there's undertraining and there's overtraining, and then there's the sweet spot in between where you're going to get the maximum benefit from your exercise training. It's the same thing with ozone. There's a narrow window in which ozone works properly. If we introduce too much ozone, we're going to have oxidation and we're going to have damage to the tissues. If we don't use enough ozone, it's just not going to have much of an effect. So there's a sweet spot. I would encourage people to have a copy in your office of the Madrid Declaration, because I'm not going to go into a lot of detail on dosing. I don't have the time today, but the Madrid Declaration has a very good explanation of dosing with various applications of ozone. And I would encourage you to have that as your Bible, your reference source, so that you understand the different methods of administration, you understand the dosing for different methods of administration for different conditions, different things you want to achieve. If your objective is to kill things, then you're going to use a high dose. So, for example, with limb bagging, if we want to disinfect the area, we're going to use a higher concentration of ozone. If we want to gently stimulate the immune system for a patient who needs that gentle stimulation, we're going to use a dose on the lower end of the range. The Madrid Declaration. They revise it every 5 years, I believe. You can get a copy online. So and then there's a sweet spot in between that's more of an immune modulating effect. And that's usually where we're going to be. Now in our clinic, we will use a higher dose in the higher end of the range if we have a patient, for example, with autoimmune condition, because we want to have a slightly suppressive effect on the immune system if that's what the patient needs. For most patients, we're going to be in the middle. And then we have patients who are in a weakened condition. For some reason, we don't want to overwhelm their system. We're going to use a lower dose. That's just a very quick overview of dosage. But just be wary about dosage. Dosage is key. It's crucial. You have to understand dosage if you're going to use ozone. So this is just about Dr. Medina covered this a little bit, but the NRF2 is responsible for a lot of the beneficial effects of ozone. Medical ozone therapy, controlled oxidative stimulus signaling, mild oxidative stress. That's the key. Mild oxidative stress activates NRF2 pathways, which results in antioxidant defense, mitochondrial support, immune modulation, improved microcirculation, which then the end result is enhanced tissue responsiveness. And that's what we're going for if we want to use ozone in combination with stem cells and exosomes. So if you want to know how ozone works, this is it. It's NRF2. The NRF2 pathway leads to all the beneficial effects that you see here. NRF2 is a key transcription factor that regulates cellular defense response to oxidative stress. When activated, NRF2 induces the expression of many protective genes involved in antioxidant defense, detoxification, mitochondrial function, and anti-inflammatory signaling. So here again, the downstream biological effects can include modulation of inflammatory cytokines, macrophage polarization, and angiogenesis signaling, and improved tissue repair microenvironment. The end result is we want better regenerative signaling. And again, you don't want to be giving stem cells and exosomes to a patient who doesn't have good regenerative signaling. Their signaling is more focused on defensive signaling because the body's in a defensive state because it's damaged and there's oxidative stress going on. So when we talk about systemic ozone approaches, there's most popular, most common, and most practical is major autohemotherapy. For those of you who are not familiar with it, we withdraw blood from the patient. Average, it depends on the weight of the patient, but it's average 100 cc's of blood. We have a little bit of blood thinner and in the IV bag, and we infuse the blood with ozone, then we return the blood to the body. Interestingly, ozone is no longer ozone. Is when it comes into contact with biological fluids like blood, within seconds, it's not ozone anymore. It starts this cascade of biochemical reactions that we looked at. Just interesting to note that we in our clinic we use a lot of ozonated saline, which was I would say discovered in Russia, but is now used all over the world. Adriana Schwartz, with whom I studied, she actually studied in Russia. She brought it to the world's attention, and now it's being used all over the world. It's becoming more and more popular. And the key difference between major autohemotherapy and ozonated saline is that with ozonated saline, you're not ozonating the blood directly. You're suspending the ozone in a saline solution. The saline solution is then dripping in by IV into the patient's circulatory system. And the key difference to be aware of is that you're exposing a larger quantity of blood directly to ozone than as is the case with major autohemotherapy. So ozonated saline accentuates some of the antimicrobial properties of ozone, and so sometimes we might use that for people who have microbial issues in the blood. For example, there's been studies done on COVID, and they all used the ones that I know of used ozonated saline rather than major autohemotherapy because you're dealing with a viral condition. In the interest of time, I'm not going to go into the other ones, but you can see what they are here. These are some of the injections that we do in our clinic. We do caudal ozone injections, usually combined with dextrose. It's good for a lot of spinal conditions, disc disease, spinal stenosis, etc. We do quite a few joint injections, intra-articular injections of ozone, usually with the prolozone, where we're also injecting some fluids. And we also do local periarticular type injections of ozone. But we use primarily we're using prolotherapy and PRP for the periarticular work. But we complement it with ozone quite a bit. This is not actually a picture of supraspinatus tendon, but it somehow got matched up like that. But we do use it mostly for joints, I would say, in our practice. It's also used, there's limb bagging on the right. It's also used for aesthetic procedures and for those types of things. So, all right, proposed local effects of ozone therapy. You've got the anti-inflammatory signaling, modulation of pain mediators, improve local circulation. This is very well documented and studied. And that's why ozone is terrific if you got a client who's inflamed, got an inflamed joint and is in pain, and you want to put out the fire. Ozone is a great way to do that. So this slide is showing how there's different possible ways of combining ozone and exosomes and stem cells. One way is a systemic treatment of ozone, where you're preparing the body as a whole for a subsequent introduction of the stem cells and exosomes. And again, we refer to as preconditioning, because you're enhancing the biological environment for the regenerative therapies. That's the first item here is the systemic preconditioning. Another way of combining these materials would be local environment modification. That's where you're doing an injection of local ozone followed by local regenerative injection. And the goal again is to reduce the inflammatory burden, improve tissue microenvironment, prepare local tissue for regenerative therapy. There is a way of using ozone subsequent to stem cells and exosomes, but you have to be very careful here. And I'll give you the guidelines, but you really want to wait a good period of time. If you're doing local injections, you want to wait 2 to 3 days after the exosomes to do a local injection of ozone. You want to wait 5 to 7 days after stem cells. So here again is the importance of this slide is to show that the reactive oxygen signaling occurs within minutes to hours after the ozone is administered. The gene expression changes, activation of repair mechanisms is hours to days. So the concept that we
Other questions till break time. Thank you. I apologize, but it's a really tight schedule because
if
of the
anybody
number of
has any
speakers.
questions, let me know about the dosing. Okay.